we are going to talk about the relevance, the anatomy, and the biomechanics of ulnar styloid fractures. We are going to talk about the classification systems very briefly. There are not many of them. Evidence supporting the neglecting fixation of the ulnar styloid, and evidence supportive of fixing the ulnar styloid, the treatment recommendations and the operative techniques in brief, and the post-op protocol and the caveats when you're dealing with these particular fractures. So the relevance of ulnar styloid fractures exists along with a lot of controversy, and in almost every hand or wrist conference, there is so much of debate that is generated around this small little piece of bone. So almost 50 to 65% of distal radius fractures are associated with ulnar styloid fractures, and they commonly proceed to non-union, and most of them are asymptomatic, but a few will be symptomatic. And it is these cohort or this subgroup of patients where we need to think about some kind of treatment. And ulnar styloid fractures need not necessarily be associated with poor outcomes all the time, and they need not be associated with instability all the time. So we will, through this talk, understand which are those fractures that merit fixation, identifying them, and dealing with them. This particular paper by Hawk and Palmer, from which the classification of ulnar styloids is derived, also spoke about symptomatic non-union and the problems that are associated with symptomatic non-union of ulnar styloid fractures. And basically, when the fracture is through the base of the styloid, which is where the TFCC is attached, that is when instability would occur. There may be associated TFCC tears. Non-united fragments may act as an irritating loose body about the carpus, and there may be impingement of the ECU sheath. This particular slide shows, this is a cadaver dissection coronal view, shows the components of the TFCC that we now have come to appreciate. So there is a proximal component which is attached to the base of the styloid at the fovea through Sharpie's fibers, and the distal component is more or less a loose soft tissue collagenous structure. And therefore, you can imagine that any fracture through the base of the styloid, which would involve a rupture of the TFCC, so the fragment which is attached to the TFCC would obviously then give rise to DRG instability. And why do we talk so much about such a small piece of bone? What is this controversy? Why is it that we keep on debating about it? It is when we look at the schematic diagram here, and when you look at the DRU as a load-bearing joint, you would understand the importance of the ulna, which acts as a counterforce against the radius when you are doing prehensile movement, such as lifting weights, where a large resultant force is generated at the DRUJ. And you need the TFCC and the styloid intact to go through the complete range of movement, as well as to be able to perform function with a stable DRUJ. The classification is named after Palmer, where you have type 1 and type 2. Type 2 is at the base. It could be a horizontal or an oblique fracture, whereas the distal fractures are those of the tip and the mid portion. And then it doesn't take too much of imagination to understand that the fractures at the base, whether it is horizontal or oblique, which would perhaps result in greater disability from instability of the DRUJ. And this particular slide figure gives you the approximate incidence. The base fractures account for almost 40% of the fractures, whereas the distal fractures are far less in frequency. When you look at DRUJ instability, which is associated with DRUJ fractures, we should understand that 3 to 37% of distal radius fractures may have an associated DRUJ instability. And ulnar styloid fractures, according to Frickman, occurs in almost 60% of patients having distal radius fractures. However, it is remarkable that fewer than 10% of these patients would necessitate some kind of fixation of the distal ulna or the styloid. So let us proceed to the second part of the talk, where we are going to just very briefly go through literature, a few papers that are important, and this particular paper by Sebastian Sauer and Jesse Jupiter and David Ring. This was a multi-center study, which was a retroprospective kind of cohort level 3 study They had a case control arm, and they studied 132 patients with untreated ulnar styloid fractures, comparing displaced versus non-displaced, more than 2 millimeters of displacement. And they excluded 16 patients from this study where the ulnar styloid process was fixed per the preference of the operating surgeon. And they also took into consideration the ORIF for the distal radius. And you can see here when they compared the contralateral side of ulnar fracture and no ulnar fracture, there was no significant difference in all the parameters between the ulnar fracture and no ulnar fracture cohorts. What is also very important to note is that there was no difference in the flexion at 2 years, no difference in ulnar deviation at 2 years, and no significant difference in the grip strength at around 2 years. So in all their parameters that they looked at, right from the dash scores to the range of motion to the grip strength, and they looked at the Gartland and Worley demerit system, you can see that they have almost similar outcomes. And they concluded that unrepaired ulnar styloid fractures, there is no clinical difference versus no fracture in the setting of distal radius fractures undergoing open reduction internal fixation. So this particular study then perhaps brings to mind the study that was undertaken and reported by Mark Ross from Australia. So there must be other factors other than the styloid process that contribute to DRUJ stability. This particular slide is a drawing which shows the distal oblique band of the intraosseous membrane. And when the proximal fragment is medially displaced, it is imperative to reduce this beak that is caused and thereby retensioning the distal oblique band and thereby stabilizing the DRUJ even in the presence of an ulnar styloid fracture, and that would therefore result in a stable DRUJ. Another study from Japan, it was a retrospective cohort of about 118 patients, and they underwent volar locking plate, and no ulnar styloid fractures were treated operatively. And when they looked at their results, they concluded that ulnar styloid wrist pain improved gradually with time, and there was no significant difference in the incidence of ulnar wrist pain between their groups, where they had 3 groups, no fracture, control group, and where they had a base fracture and a tip group. And they concluded that there was no relationship between ulnar pain and the union of the ulnar styloid fracture. Another study by David Ring had almost similar kind of observations, and they did not immobilize the DRUJ when they had a good reduction of the distal radius fracture and fixation. So all of these studies are in favor of not fixing the ulnar styloid fracture, and you see why. When you have a when you have a distal radius fracture which is fixed well, restoring all parameters, the DRUJ lends itself to being stable without the need for fixation of the ulnar styloid process. So another study from Douglas Sammer and Kevin C. Chung, here they looked at the Michigan Hand Questionnaire, and they concluded that with a stable DRUJ after distal radius fracture, which has been fixed and all parameters have been restored, regardless of the ulnar styloid fracture size, the degree of displacement, or the presence or absence of non-union, their patients went on to have good outcomes. So I'll just kind of rush through these slides in the interest of time. So the summary thus far has been that after ORIF of the distal radius, there is no difference in outcomes when you compare ulnar styloid fractures versus those who have no fractures, and there is no difference when the TFCC fixation and immobilization has been done for Frickman type 2 and 6. Let us look at a couple of studies that prove otherwise, which are in favor of fixation of ulnar styloid process. This was a study from Cleveland from Philip Blazar's group. They did a retrospective review, and they found that ulnar styloid fractures that were displaced by more than 2 millimeters and were not addressed and had DRUJ instability went on to have poorer outcomes in terms of stiffness of the wrist joint, relating to loss of movement and ulnar styloid wrist pain. And therefore, they recommend fixation of the ulnar styloid fracture if it is grossly displaced. Another study from Tommy Lindau and Swedish group. It was a prospective study where they looked at the distal radius fractures along with ulnar styloid fractures, performed diagnostic arthroscopy for distal radius fractures, and DRUG's instability was determined by clinical examination, and all unstable fractures lend themselves to a poorer outcome on the Gartled-Verdi score. So they concluded that in their study, where people had instability of the DRUJ on clinical examination, they had worse clinical outcomes and pain scores were worse. So this begs the question, if Shakespeare were to be alive today, he would have perhaps asked to fix or not to fix the ulnar styloid. And what are the recommendations? Ulnar styloid fractures require fixation or stabilization when they are the cause of DRUJ instability, either partly or wholly. And how do we determine that? We determine that by examining the DRUJ stability after you have fixed the distal radius fracture in 3 rotations and comparing it with the opposite side. And if you find it to be unstable, you should first ask the question whether your distal radius fracture has been adequately fixed with the restoration of all normal parameters, and then you would proceed to stabilizing the styloid. Here is an example of a distal radius fracture. You can see that there is an ulnar styloid fracture. And when we had fixed the distal radius, we examined the DRUJ and found it to be stable. And therefore, we just chose to neglect the styloid fracture. And this, my patient went on to have good outcomes. So if stabilization is deemed necessary, multiple options are available. The fracture configuration will dictate your choices, and the fragment size will also beg the type of fixation that you would opt for. And in general, or if you were to kind of have a rule of the thumb, more distal and comminuted fragments are usually suitable for reconstruction by soft tissue reattachment by ignoring the fracture fragments, whereas basal fractures of the ulnar styloid might require some kind of fixation. And there is a litany of options that are available out there. You may use suture anchors, you may use tension band wiring, you may use screws of different types, a headless compression screw, a small fragment screw, and this particular plate, which has been recently introduced by Arthrex, I have no conflict of interest with this particular slide. So this particular implant also will give you a good fixation, especially if there is a fracture of the head of the ulna associated with the styloid fracture. So the caveats, like Dr. Sudhir Warrior showed us, did not injure the sensory branch, the dorsal sensory branch of the ulnar nerve, avoid splitting the styloid fragment, do not use excessive hardware, do not detach the TSCC attachments to the styloid, and avoid opening or elevating the ECU subsheath, because the ECU subsheath forms an extremely important stabilizing element of the DRUJ. Postoperatively, we usually begin with a long arm splint, which is converted to a long arm cast, and at around 4 to 6 weeks, that is converted to a well-molded short arm cast, and then a removable splint with graduated physiotherapy program. So in conclusion, recovery of stability, motion, and strength is consistently achieved in most of these fractures. Outcomes do not correlate to the bony union, and fibrous union is often adequate, but there is a small cohort of patients that would beg fixation. We need to identify them with examining the DRUJ in 3 rotations, comparing with the opposite side after you have fixed the distal radius fracture. And with that, I wish you well, and thank you very much for the opportunity to speak here.